Welcome to the deep dive. Today we're plunging into the world of acquired portosystemic shunts, or APSS. Now that sounds pretty complicated, I know.
It does sound a bit technical, yeah. But
Totally.
basically, it's about abnormal blood vessels. They develop and reroute blood flow so it bypasses the liver.
And that bypass is a big deal, isn't it? Because the liver is supposed to be filtering that blood.
Absolutely crucial. It's like the body's main processing plant for blood coming from the gut. If you bypass it, well, all the stuff the liver normally removes, toxins, waste products, they just keep circulating.
Which can cause all sorts of problems, I imagine.
A whole range of health issues, yeah?
Exactly. So for this deep dive, we've pulled together quite a bit of medical literature. We want to really unpack, what causes these shunts, what are the signs to look for, how vets diagnose them, and the strategies for managing them. And even if APSS isn't a term you hear every day, understanding it gives you some really valuable insights into liver health, blood flow, how interconnected things are. So our mission today, break down APSS. Make it clear, digestible, focus on the key takeaways and why it all matters. Okay, ready to jump in. Let's start with the basics.
Sounds good. So acquired portosystemic shunts, APSS, they don't just pop up out of nowhere. They actually develop after another condition kicks in.
Yep.
That condition is called portal hypertension, often just called PH.
Portal hypertension, so high pressure in the portal vein, that big vessel going to the liver.
Exactly. That's the core issue. Elevated pressure in that specific vein.
And I guess that pressure doesn't just build up randomly. Our sources mention different categories, different reasons for that high pressure.
That's right. It helps to break it down. First, you have what we call prehepatic causes. That means there's an issue, like an obstruction, in the portal vein before it even gets to the liver.
Okay, before the liver. Makes sense.
Then there's intrahepatic portal hypertension. Now, the problem is actually inside the liver itself.
Within the liver tissue.
Yeah. Think of the liver like a filter system with lots of channels. Intrahepatic means there's increased resistance within those channels. And, it could be further broken down depending on exactly where the bottleneck is before the main filtering units within them or after them. Sinusoidal, sinusoidal, post-sinusoidal.
Got it. So different locations within the liver causing backup.
Right. And finally, there are posthepatic causes. These happen in the veins draining blood away from the liver. Sometimes it's even related to heart problems or issues with the big vessels connected to the liver's outflow.
Wow. Okay. So pre, intra, post. Basically problems before, within, or after the liver.
That's the gist. And notice how many of these point back to some kind of chronic damage or scarring or an obstruction that stops the liver from handling blood flow normally. It's that sustained high pressure that eventually triggers the body to create these bypass vessels, these shunts.
That sustained pressure is the key. Okay. So knowing where the pressure can come from, who actually gets APSS, do we see trends, particularly in, say, pets?
We do. In dogs, the literature really points to chronic necroinflammatory liver disease as the most common culprit. Basically, long-term inflammation and liver cell damage.
Okay. Chronic liver disease in dogs. Anything else?
Yeah, it's not the only thing. APSS can also show up in dogs with something called ductal plate malformations. That's actually a congenital thing, affecting tiny bile ducts inside the liver from birth.
So a developmental issue.
Exactly. And then less commonly, you might see it with non-cirrhotic portal hypertension, sometimes in dogs recovering from really severe liver injury. And interestingly, sometimes if surgery to fix congenital shunt didn't go perfectly or wasn't tolerated well.
Okay. What about cats? Similar picture.
There's overlap, but some differences too. In
Uh-oh.
cats, those ductal plate malformations are also quite significant.
Right.
The sources also mention rare cases tied to severe heart failure. And, like dogs, sometimes issues after surgery for a congenital shunt. Oh, and another one to mention, if there's a blockage in the main bile duct outside the liver, an extrahepatic bile duct obstruction, that lasts for more than about 6 weeks.
Yeah.
That prolonged backup seems to be enough to trigger it too.
6 weeks. That duration seems important.
It does. Seems to be a critical time frame for that pressure to cause changes.
And are there specific breeds we should be aware of? Ones more likely to have these underlying issues?
Yes, definitely. For those ductal plate malformations we mentioned, the sources highlight Persian and Himalayan cats.
Okay, Persians and Himalayans.
And in dogs, boxers seem to have a higher incidence.
Boxers. Interesting. So it suggests there might be a genetic link in those breeds, making them more prone to the liver problem that leads to APSS.
Seems likely, yeah, a predisposition.
So knowing that, what are the actual signs? What might an owner or a vet notice that makes them think, maybe this is APSS?
Good question. Let's talk symptoms. The big one often is something called episodic hepatic encephalopathy, HE for short.
Hepatic encephalopathy. Brain-related, sounds like.
Exactly. Yeah. It refers to these neurological or behavioral changes that kind of come and go. Episodic.
Okay. Like what kinds of changes?
Well, it can be a whole spectrum. Confusion, acting strangely, not like their usual selves, sometimes even temporary blindness.
Wow, blindness too.
Yeah. And you also often see things like increased thirst, increased urination, maybe they're off their food, lethargic, vomiting. The neurological signs themselves can be quite varied, affecting different parts of the nervous system.
And you said episodic, so these signs can wax and wane.
That's a key feature. They can come and go. And what's really telling is that these signs often improve, at least for a while, with supportive treatment. That can be a big clue.
Ah, that response to treatment.
Yeah.
Okay. Are there other, maybe more physical signs?
Yes. Ascites is another one. That's fluid building up in the abdomen.
Right, a swollen belly.
Exactly. But it can be variable. Sometimes it's there, sometimes it's not so obvious.
Okay.
And then there's something called hypertensive splanchnic vasculopathy. Bit of a mouthful.
It is. Break that down for us.
Okay, so hypertensive means high pressure.
Yeah.
Splanchnic refers to the abdominal organs, and vasculopathy means diseased blood vessels. So basically, the high portal pressure causes abnormal, fragile blood vessels to develop in the gut.
Uh-oh. Fragile vessels in the gut. Sounds like bleeding risk.
Huge risk. It can lead to bleeding, ulcers in the stomach or intestines. This can be really serious, even life-threatening, especially if their clotting isn't normal either.
And I guess bleeding in the gut would make the HE worse, too.
Absolutely. That breakdown of blood in the gut releases ammonia and other toxins, which then bypass the liver and hit the brain. Vicious cycle.
Yikes. What are the signs of that specifically?
With the vasculopathy, you might see anorexia, vomiting, maybe diarrhea, belly pain, anemia, obviously, from the blood loss. Sometimes even iron deficiency shows up on blood tests.
Okay, that's a whole other set of serious problems stemming from the high pressure. Anything else? Other body systems affected?
Yes, the urinary system can get involved too. Specifically, we worry about the formation of ammonium biurate stones.
Stones. Okay, how does that link to the shunts?
It comes back to the liver not doing its job. The liver normally processes ammonia. With shunts, ammonia levels build up in the blood. That, combined with how the body handles uric acid, can lead these specific types of crystals, ammonium biurate, to form in the urine.
And crystals can form stones.
Exactly. Which can then cause blockages, especially in male animals. So you might see blood in the urine, straining to urinate, going more often, signs of a urinary tract issue.
So neurological signs, belly fluid, gut bleeding, urinary stones. Quite a wide range of potential clues.
It really is, which, as you can imagine, can make diagnosis a bit tricky sometimes.
I bet. Okay, let's dig into the why. What's actually happening under the hood? What causes these shunt vessels to form in the first place?
So at its core, APSS is about the body developing these multiple, often kind of tangled-looking new blood vessels. These vessels create connections, shortcuts basically, between the portal vein system, which should be going to the liver, and the main systemic circulation that goes to the rest of the body.
So the blood literally detours around the liver.
Exactly. It bypasses the filter. And one thing that makes this easier anatomically is that the portal vein doesn't have valves like many other veins.
Ah, no one-way doors.
Right. So when that pressure, the portal hypertension we talked about, starts to build up, there's nothing stopping the blood from flowing backwards or taking the path of least resistance through these new developing shunt vessels.
Makes sense. The pressure forces the blood to find an easier way out. And we already touched on the broad categories of portal hypertension, prehepatic, intrahepatic, posthepatic. Can we get a bit more specific about the actual conditions that cause that pressure?
Sure. A really big one is diffuse liver scarring.
Yeah.
We call it fibrosis. Sometimes it progresses to full cirrhosis. Sometimes it's fibrosis without cirrhosis. But that scarring increases resistance to blood flow.
Okay, scarring is a major one.
Then there's that chronic unresolved blockage of the main bile duct outside the liver. Remember, the one lasting over 6 weeks.
Got it. Bile duct obstruction.
Blood clots forming in the portal vein itself can do it. That's portal vein thrombosis.
Right.
Sometimes we see something called idiopathic portal hypertension, where idiopathic just means we can't pinpoint the exact cause of the high pressure.
Ah, the mystery category.
Kind of. There's also non-cirrhotic portal hypertension, which involves the tiny portal veins inside the liver getting obliterated or disappearing, but without the widespread scarring of cirrhosis.
Okay.
And hepatic sinusoidal occlusion syndrome, another mouthful, where the very small capillary-like vessels within the liver, the sinusoids, get blocked.
Lots of different ways the plumbing can go wrong inside or around the liver.
Exactly. And less commonly, you might see clots or narrowing further up the portal vein in the abdomen, or even very rare congenital things like the portal vein being absent from birth or abnormal artery vein connections in the liver.
That's quite a list. It really highlights how many different underlying problems can lead down the path to APSS.
It really does.
And you mentioned earlier that certain things can trigger those episodes of hepatic encephalopathy, the HE, once the shunts are there.
Yes, that's a crucial part of management, actually. Knowing the triggers. High-protein meals are a classic one.
Because digesting protein produces ammonia.
Exactly. More ammonia for the bypassed liver to not deal with. Bleeding in the gut, like we discussed with the vasculopathy, is another major trigger.
Right.
Kidney problems can make it worse. Imbalances in blood chemistry, like electrolytes being off or the blood becoming too alkaline.
Okay.
Even things like blood transfusions or conditions causing red blood cells to break down faster. Infections are a big one, too. And certain medications can sometimes precipitate an HE episode.
So lots of potential triggers to be aware of for pets that have APSS.
Definitely. Managing those is key.
And just to circle back to those ammonium biurate stones, we established the link to ammonia buildup. It's really about the liver's metabolic jobs being skipped, right?
Precisely. The liver is central to processing ammonia into less harmful urea, and it's involved in uric acid metabolism too. When shunting bypasses these functions, you get high ammonia and altered uric acid handling, leading to those specific crystals forming in the urine.
Got it. Okay, so we understand the causes, the signs, the mechanisms, but diagnosing it sounds like a challenge given all the possibilities. How do vets actually pin down APSS?
Well, it is often a process, putting pieces together. First, you have to think about all the other things that could cause similar signs, the differential diagnoses.
Right, because the signs overlap with so many conditions.
Exactly. Neurological signs could be infection, toxins, epilepsy, lots of things. Gut signs, maybe inflammatory bowel disease or a foreign object. Urinary signs could be a simple infection or different types of stones, increased thirst, diabetes, kidney disease. The list goes on. Abdominal fluid could be heart failure, other liver issues.
So step one is ruling out a lot of other stuff.
Pretty much. Then you look for clues in the routine lab work.
Okay, what might you see on, say, a standard blood count or chemistry panel?
Blood work can be really helpful. A common finding is small red blood cells microcytosis. They can point towards shunting itself, or sometimes iron deficiency from chronic gut bleeding.
Small red cells. Okay.
Mild anemia is also pretty common.
Mm-hmm.
In cats, you might see weirdly shaped red cells called poikilocytes. Dogs might have target cells.
Little indicators in the red cells. What about the chemistry? Liver enzymes, kidney values.
On the chemistry profile, you often see low values for things the liver usually makes or processes. So low BUN, that's blood urea nitrogen, low creatinine, sometimes low blood sugar or glucose, low albumin, which is a key protein made by the liver, and low cholesterol.
So lots of lows. What about liver enzymes? Are they always high?
Not necessarily. They can be variable. It really depends on the underlying liver disease causing the APSS. Sometimes they're high, sometimes normal, sometimes only mildly increased. Bilirubin can also be variable.
Okay, so the pattern is more about the lows than the highs sometimes. What about urine tests?
Urinalysis is important too. Urine concentration can vary. But the key finding, if present, is those ammonium biurate crystals we talked about.
Finding those crystals is a big clue for the ammonia issue.
A very strong clue. You might also see blood or signs of infection like white blood cells or protein, especially if there are stones causing irritation.
Okay, so standard labs give clues. Are there more specific tests for shunting?
Yes. The total bile acids test, TSBA, is a really sensitive one for liver function and shunting. Bile acids are processed by the liver. Normally, levels are low before a meal and rise only slightly after. With a shunt, post-meal bile acids are usually dramatically elevated because the blood bypasses the liver's processing.
So high bile acids after eating strongly suggests a shunt.
Very strongly, yes. Measuring blood ammonia levels directly can also be done. It's sensitive, but the levels can fluctuate a lot, and the blood sample needs really careful, rapid handling, or you get falsely high results.
Tricky to measure accurately then.
It can be.
Mm-hmm.
But again, finding those ammonium biurate crystals in the urine is good indirect evidence that blood ammonia is probably high.
Right.
There's also an ammonia tolerance test, where you give a small amount of ammonia compound and measure blood levels. It's probably the most reliable test for confirming ammonia intolerance, but you have to be careful because it can actually trigger an HE episode.
Yeah, you wouldn't want to induce the problem you're testing for.
Exactly. This is used cautiously.
What about tests looking at liver function indirectly, like clotting?
Good point. Coagulation tests like PT, APTT, and something called PIVAA can be abnormal if the liver isn't making enough clotting factors, or if there's a vitamin K deficiency, which the liver is involved with too.
Okay.
And interestingly, another protein involved in clotting, protein C, its activity level is often low in animals with portosystemic shunts. So that can be another supportive finding.
Protein C, got it. And if there's fluid in the belly, the ascites. Analyzing that helps.
Definitely. Tapping the abdomen and analyzing the fluid can tell you a lot. With APSS due to portal hypertension, the fluid is typically what we call a pure or modified transudate, basically low in cells and protein compared to fluid caused by inflammation or infection. Checking the albumin ratio between blood and the fluid can also help point towards portal hypertension.
Okay, so lab tests build a strong case. What about actually seeing the shunts? What role does imaging play?
Imaging is absolutely critical. Plain old abdominal x-rays might show changes in liver size, often small with chronic disease leading to APSS. They could show the fluid, and sometimes you can see those ammonium biurate stones, though they aren't always dense enough to show up well.
So x-rays give some hints. What's next?
Abdominal ultrasound is usually the next step and is incredibly valuable. You can assess the liver size and texture much better, and crucially, using Doppler ultrasound, which looks at blood flow.
Ah, Doppler shows the flow direction.
Exactly. You can often directly see the acquired shunt vessels, and you can see that blood flow in the main portal vein might actually be flowing away from the liver or very slowly towards it instead of the normal robust flow into the liver. That's a huge diagnostic sign.
Seeing the blood flow backwards or diverted, wow.
Yeah. Plus, ultrasound is great for confirming abdominal fluid, looking for stones in the bladder or kidneys, and spotting those rare underlying causes like abnormal artery vein connections in the liver.
So ultrasound is key. Are there even more advanced imaging techniques?
There's something called scintigraphy, either colorectal or splenoportal. It involves injecting a tiny amount of radioactive tracer and tracking where it goes. If it bypasses the liver and shows up quickly in the heart, that confirms a shunt.
Nuclear medicine test. Does it show the type of shunt?
Not usually. It confirms a shunt is present, but typically can't distinguish between a congenital one and the multiple acquired ones. It's non-invasive, which is good.
Okay. What's the gold standard then, maybe?
Increasingly, multi-sector CT scans, computed tomography, are becoming the preferred non-invasive method. CT gives amazing anatomical detail.
Like a 3D map.
Pretty much. You can clearly see the blood vessels, map out the acquired shunts, see the liver structure, identify any underlying masses or obstructions. It gives a really comprehensive picture.
So CT is very powerful. What about actually looking at the liver tissue itself? Does a needle sample help?
A fine needle aspirate just sucking out a few cells usually isn't enough to figure out the underlying cause of the APSS.
About enough information.
Right. To really understand what's going on in the liver tissue, the fibrosis, the inflammation, the ductal plate malformation, whatever it is, you generally need a liver biopsy.
A bigger piece of tissue.
Exactly. Either taken during surgery as a wedge sample, or often nowadays via laparoscopy using keyhole surgery. That tissue, examined under the microscope, is often needed for the definitive diagnosis of the primary liver problem that led to the shunts forming.
Okay, so biopsy confirms the underlying why.
Precisely. The appearance of the liver, both just looking at it and microscopically, can vary a lot depending on what caused the APSS.
Right, so diagnosis is a combination of history, signs, lab tests, imaging, and often biopsy. It's quite the workup.
It definitely can be.
Okay, so let's say we have a diagnosis. APSS is confirmed. How is it managed? What are the main goals?
Management really focuses on controlling the consequences of the shunting, especially the hepatic encephalopathy, and trying to manage the underlying liver disease if possible. If an animal comes in with severe AG signs, hospitalization for intensive supportive care is usually the first step.
Get them stabilized first.
Absolutely. And then nutritional support is just fundamental. It's a cornerstone of managing APSS long-term.
Okay, diet is key. What kind of diet?
The main goal is a balanced diet that's restricted in protein, but only to the level the individual animal can tolerate without showing signs of HE. It's not about eliminating protein entirely, just controlling it carefully.
Tailored protein levels.
Exactly. You adjust it based on how the animal responds. Often we start with commercially available prescription diets designed for liver disease or sometimes kidney disease, as they tend to be protein restricted and formulated to be easier on the liver.
What about the type of protein? Does that matter?
It can, yeah.
Yeah.
For dogs, sometimes proteins from dairy or soy sources are preferred because they tend to generate less ammonia during digestion compared to meat proteins.
Okay. But cats are different, right? They need meat.
They do. Cats are obligate carnivores, so they still need meat-derived protein. The key is just controlling the amount and ensuring the diet is high quality and digestible.
Makes sense. What if they won't eat?
If an animal really isn't eating well, sometimes parenteral nutrition, giving nutrients intravenously, bypassing the gut altogether for a short time, might be necessary to provide support.
Okay, so diet is huge. What else is involved in management?
Client education is absolutely massive. Owners need to be partners in this. They have to learn to recognize those subtle early signs of HE returning.
Right, catching it early.
Exactly. They need to understand the risk of urinary stones, especially in male dogs where blockage is more likely. And they need clear instructions on giving medications, monitoring at home, and when to call the vet.
Makes sense. What about medications? Are there drugs used to manage APSS?
Yes, medications play a big role, especially for complications. If there's concern about gut bleeding from that hypertensive vasculopathy,
The fragile vessels.
right, then medications to reduce stomach acid or protect the gut lining might be used. Things like proton pump inhibitors or sucralfate.
Okay, what about the ascites, the belly fluid?
For managing fluid buildup, the first steps are usually restricting exercise and putting them on a low-sodium diet.
Less salt, less fluid retention.
Exactly. And then diuretics are often needed. Furosemide is a common one, often used in combination with spironolactone, which helps counteract potassium loss. Sometimes, if fluid is really hard to control, other diuretics or procedures might be considered.
And you mentioned avoiding dehydration and low potassium.
Crucial, both dehydration and low potassium levels can significantly worsen hepatic encephalopathy. So maintaining good hydration and monitoring electrolytes is really important.
Got it. And I guess you have to be careful with any drugs you give these animals.
Absolutely. Because the liver is the main site for metabolizing many drugs, its reduced function and the shunting mean drugs can stick around longer or have stronger effects. Dosages often need to be adjusted carefully, and you always have to be thinking about potential drug interactions.
Good point. So it's a very personalized approach, diet, meds, owner vigilance. How do you monitor progress long term?
Ongoing monitoring is key. Owners watching behavior and appetite for any hint of HE is number one.
Daily observation.
Yes. Then regular vet checkups are essential. We monitor their clinical signs, check their body weight and condition, measure their belly girth if ascites is an issue. Routine blood work helps track liver function markers, kidney values, protein levels, electrolytes.
Okay.
And urinalysis is important too, specifically looking for those ammonium biurate crystals to see if stone risk is being managed.
Do you keep checking bile acids, that TSBA test?
Interestingly, no. Once you know shunts are present, the TSBA test isn't really useful for monitoring management. It's likely to stay elevated because the shunt is still physically there, even if the animal is doing well clinically. Plus, some medications used can affect the results anyway.
Ah, okay. So it's more about clinical signs than other lab work.
Exactly.
Yeah.
The overall goal of all this monitoring and adjustment is to minimize how often and how badly they experience HE, prevent those urinary stones from forming, and keep any fluid buildup under control.
Makes sense. Can anything be done to prevent APSS in the first place?
Well, since APSS develops secondary to other problems, prevention really means addressing those underlying issues early and effectively. So prompt diagnosis and treatment of chronic liver disease or bile duct obstruction is key.
Treat the primary problem before it causes the shunts.
That's the ideal scenario. And in cases of congenital shunts, careful management, sometimes involving staged surgery if full correction isn't immediately possible, might help prevent the kind of portal hypertension that could lead to acquired shunts later on.
Okay. But despite best efforts, complications can still happen.
Unfortunately, yes. Even with good management, things can still go wrong. They might have recurrent gut bleeding, struggle with dehydration or electrolyte problems, develop worsening kidney disease over time.
Right.
The underlying liver failure might progress. The HE itself can lead to severe complications like seizures or coma. Major bleeding episodes are a risk, or they could develop serious systemic infections, sepsis.
It sounds like the outlook, the prognosis, must really depend on what caused the APSS in the first place.
It absolutely does. The prognosis is highly dependent on the specific underlying cause and how well that primary condition can be managed.
So some causes have a better outlook than others.
Generally, yes. If it's related to, say, chronic but non-progressive liver disease or fibrosis that can be medically managed, we can often significantly extend their lifespan and maintain a good quality of life for quite some time. Animals with things like non-cirrhotic portal hypertension or those ductal plate malformations, for example, can potentially live for many years with consistent, appropriate long-term care.
So there can be hope for good long-term management in many cases.
Definitely. It takes commitment, but good outcomes are possible.
This has been incredibly informative, a real deep dive into acquired portosystemic shunts. It's so clear that, this is a really complex condition, but it fundamentally stems from those underlying problems messing with blood flow and liver function.
That's the core of it, yeah. The link to portal hypertension is key.
And the key takeaways for me are really that connection to high pressure, the huge variety of signs it can cause, from brain issues to bladder stones, the different underlying causes, and how vital that thorough diagnosis and really tailored multi-part management plan is.
Well put. It's rarely a simple fix. It's about managing a complex situation.
Yeah. And it's so important, I think, for everyone listening to remember that while we've covered a lot based on our sources, every single case is individual. How it presents, how it progresses, it can vary a lot.
Absolutely. Textbook descriptions are one thing, the real patient is another.
For sure. If you want to explore this further, I'd really suggest looking into related topics, maybe dig deeper into specific liver diseases or the mechanics of portal hypertension itself, or even more about hepatic encephalopathy. There's lots more to learn.
Always more to learn in medicine.
Always. And here's something to chew on after we wrap up. Considering how the body creates these APSS detours when normal pathways are blocked or under pressure, what other conditions, maybe seemingly unrelated ones, might also involve the body developing similar kinds of bypass mechanisms or compensatory pathways in response to some underlying chronic stress or dysfunction? Something to think about.
That's an interesting question. Thinking about adaptation and compensation in biology.
Exactly. Well, thanks so much for sharing your expertise today, and thanks to all of you for joining us for this deep dive.